All right. Good evening, everyone. As people are coming into the room, we're going to give it just a second. When you work with such great clinicians, they see patients all day. And so, sorry, we are about 1 minute behind, but it's because our clinicians are doing great work. So, for those who are just coming into the room, we're going to give it just a minute. We kind of watch till the ticker stops. We have about 200 folks registered for tonight. So, really excited about that and excited about this topic. And we will give it just another minute. All right, the ticker's still coming up, which is exciting. This is a great conversation we're going to be having tonight. Um, if you all have questions as we go through tonight, for those who are just joining, you can certainly put those in the Q&A and we'll pick those up in the back end. And for those we have time with, we'll have time for, we will add those in um, at the very end. So feel free to put them in the Q&A. If we don't get to all of them, we will do our best. But we do invite you to put your questions in. The chat should be off. We do that for security purposes. But if you can't find the Q&A, you should be able to find it at the bottom of your screen. All right, I think the ticker has stopped for a minute, but I just want to welcome everyone tonight. I'm Carrie Howell, the CEO for American Migraine Foundation, and it is always my privilege to be here and really kick these off because I think it's the bread and butter of what we're doing with education. These are so important, and we hear the community. We look at things that are coming through from emails and chats and other conversations we're having with other partners, and we're like, what do people need to hear more about? And so this month being Black History Month, I was really important as we were looking at webinars and the topics that we talk about disparities. And we know that there's still the folks across the country who can't get the care they need. And so tonight's topic is really important. Um, I also want to tell you if you're joining us tonight and you're new to AMF, we'd love to have you join our Move Against Migraine page on Facebook. We have a strong Facebook page. We have a public facing one and we have one that's closed. And we'd love for you to join those. Really, it's a great place just to come and ask questions. If you are having prior auth issues or you're having issues with new medications, that is not medical advice. It's definitely patient to patient encouragement, feedback, and those types of things. So we'd love to have you join that. We'll put in the chat the name, how to get to that, what the link is. And also just make sure you're getting our e-news because we have so many great opportunities we want to share with you from clinical trials to things like webinars. To maybe new medications that are coming out. So we'd love to have you join that as well. And that's on the bottom of our website, and we'll put that in as well. So also, I have to always bring this up because we're particularly proud that if you've been following us for a little while, you've seen us talk about patients being visible who have migraine. And for those of you who've heard this spiel before, I'm so sorry, but we also feel like this is so exciting. We created this pin, and some of you have seen this, and it's actually just a depiction of a PET scan of a patient with migraine. And we put this on, and we want to make sure that patients feel like that you are visible. This is a brain disease. And so having this depiction really to us was that this is something that really is real. This is not a made up. This isn't just a headache. We've also even put it on water bottles and bags. We don't do it because we're making tons of money. We want you to be able to show people, have a mug or have something where you're on a call and you hold it up and they're like, "What is that?" And like, "Oh, it's a PET scan of someone with migraine." And it's really for all of us to get the word out about migraine being a brain disease. So, but thank you all for being here tonight. We have just tons of things we'd love to share with you, but I'll kick it off to you, Dr. Monteith, and otherwise I'll just talk the entire hour about American Migraine Foundation. So, I'm going
Well,
to join the panel tonight and just kind of sit in and learn as well. So, over to you.
yeah, great. Well, welcome to everyone. This is really such an important topic, as Carrie mentioned, and we have an all-star team here on, and it's great that, as mentioned, with everyone's busy schedules, we were able to get on this date and really discuss a really important topic. And as I just kind of look at our panel, I'm recognizing that you all have been leaders of the American Headache Society underserved section, right? So that's incredible. And that means that you really know a lot. But let me start with introducing Dr. Larry Charleston IV, who is a professor of neurology, founder of Charleston Health Neurology and Head Pain Consultants and an adjunct faculty at the Jefferson Headache Center. He's certified in adult neurology by the American Board of Psychiatry and Neurology and headache medicine by the United Councils of Neurologic Subspecialties. He's a National Institute of Minority Health and Health Disparities Research Institute Scholar alum, a University of Michigan Rhodes Scholar alum, co-founder of the Charleston International in partnership with the Amway Corporation and Leadership Team Development, a fellow of the American Headache Society, a fellow of the American Neurological Association, and a fellow of the American Academy of Neurology. Dr. Charleston currently serves as an associate editor for Headache, the Journal of Head and Face Pain, and as a board member of the American Headache Society and as chair of the American Headache Society's Equity, Diversity, and Inclusion Advisory Council. He enjoys his time with his family and is an avid songwriter and music producer. Hey, do you want to sign me?
well, well, I just want to say that I am just really, really grateful to be here and to be able to share and with the distinguished colleagues, as you already pointed out, and with the American Migraine Foundation. So I'm really thankful for the invitation to speak. So,
Oh, well, we're going to have you back. And we haven't even started this. And Dr. Hope O'Brien, I've known her, like, I think we were fellowship kind of together the same year, right? So we've known each
Yes.
other for a really long time. She's a neurologist and headache medicine specialist, recognized nationally and internationally for her expertise in migraine care. She founded a comprehensive headache program integrating advanced therapies and multidisciplinary approaches, and has led pivotal clinical trials, authored numerous publications, and lectured worldwide. Dedicated to education and mentorship, she has developed curriculum and trained future leaders in neurology while serving in national leadership roles with major neurological organizations. With an executive MBA from Xavier University, she combines clinical excellence, scholarship, leadership, community engagement to advance patient care in the field of headache medicine. Welcome.
Thank you.
So, what do you do on your spare time?
Sleep.
And last but definitely not least, Dr. Angeliki Zagontas is originally from Greece. I guess you're going to invite me soon one day.
Open invitation.
And grew up in central Pennsylvania. She received her medical degree from Penn State College of Medicine in Hershey, Pennsylvania. She completed neurology residency at Albert Einstein College of Medicine, Montefiore Hospital, and headache fellowship at Brigham and Women's Hospital, Harvard Medical School in Boston. She's currently an assistant professor of neurology at Harvard Medical School and practices general neurology and headache medicine at several sites, including Southern Jamaica Plain Community Health Center. Is that in Jamaica?
No. Jamaica Plain, neighborhood of Boston.
Okay. Just wanted to be clear. Boston VA and the Graham Headache Center. She's chair of the American Headache Society Underserved Populations Special Interest Group and has published research about underserved populations. And she is treated in Bronx in Boston and using nationally available data, Hispanic community health study of Latinos. That's exciting.
Thanks
Great.
so much.
Do you need do people know who you
No,
are?
I don't. My
You are?
accolades are nowhere, but please skip mine. Go on good to the good stuff. Other than yourself, please tell people who you are as well.
Yeah, well, I'm a professor of neurology at the University of Miami, and I'm on the board of the American Migraine Foundation. And hopefully, all know me by now because I do a lot of these webinars, and I've been on the editorial board and one of the co-chairs for some years now. They haven't yanked me off, so apparently I'm doing a good job. Oh, great. And Lindsay, do you want to just introduce yourself? I know you're off camera.
Um, Sure. I'm ready for that. I'm just honored to be here with the American Migraine Foundation as well. So I came on board. There I am. And so honored to work with these clinicians, and you are in good hands tonight. So again, I'm just honored to be a part of this work. So enjoy. You are with the best of the best. Thank you.
Great. So I think really it's important to think about, there's been so many advances in migraine care, and it's really exciting to see all the pharmacologic advances, all the research in different areas. But it's important that we get care to all people, no matter what they look like, how they're packaged, where they live, right? In the big city, rural area. So really, I think that's the focus of this conversation. But when we talk about migraine prevalence and the disease burden across populations, or its primary care differences, let's focus a little bit on this thing called disparities. What is disparities in migraine care, and how does it show up in real world settings? Who wants to take that?
I'm happy to start off. So, when we talk about disparities or inequities, we're talking about differences in either how frequent migraine is, how easy it is for people to access a doctor, and rates of the more severe disease, chronic migraine. And, we like to look at the data, right? We like people who've systematically looked at this, and there's some data out there. As you all know, migraine is a very prevalent disease. Affects about 12 to 14% of the general population. A much smaller percentage suffer from chronic migraine, but I suspect that many in the audience may suffer from chronic migraine because it's much more disabling disease. And so when we look at these big studies in the United States, the migraine prevalence is pretty similar. There are a few differences that have been noted. For example, we see high rates in individuals who identify as Native American. We also have seen higher rates of chronic migraine in the highest rates in women who identify as Hispanic or Latino, about twice as high as in the white population. So we do see some of these differences, but of course that's only what we know and what's been studied. I think the other thing that's more important to me as a clinician, as a doctor, and perhaps to patients is ease in accessing headache specialists, neurologists, and that's where we see a big difference. So there's some data that show if you're Black or Hispanic, you're 30 to 40% less likely to have ever seen an outpatient general neurologist. That's for any need. And there's also data from our headache centers where if you are, identify as a race that's not white, you're also less likely to even make it through the door. And sometimes we also see differences in some of the outcomes that we measure. And so that's something that's very motivating to me. And I see it on a day-to-day basis. So like a real world example, I just want to give this is, I work at a clinic where a lot of the patients identify as Hispanic. They're insured by Medicaid. And why is that relevant? So I had a patient earlier this week, and I was going to remember to tell everybody about her. So she was on one of the CGRP monoclonal antibodies, the once monthly injections, and she's done very well, and she's been well controlled. But in January of this year, her health insurance decided they're not going to cover that. And actually, they're not going to be covering any of the migraine specific medications anymore. She's on a limited public health insurer. And so she's tried many of the traditional medications, and so we thought, what's the option? And basically, what the health insurance said, well, go to the pharmaceutical company and see if she can get these for free based on income. Well, that sounds like a nice idea, but she doesn't speak English, so even accessing the application is hard. She doesn't have a computer, so the online application is more difficult. And so here's where we start to see the barriers, right? So someone who had the financial means to pay for this out of pocket, that wouldn't have been an issue. So that's just one example of how this manifests in the real world in this kind of modern age of headache medicine.
Great. So it sounds like there are a number of barriers, and we're going to get into some of the solutions that in addition to awareness that we can do both as professionals, clinicians, and as patients. So why don't we talk a little bit about
Can I
even just getting the
can I say a little
migraine?
bit?
Did you want to
Yeah,
add
I
to
just
that?
want to add a little bit to the a little bit of the prevalence data. And one of the things that is interesting is that when we even talking about patients from LGBTQA plus communities, and there's been some studies that would suggest, and this is just a study, so the sample, I mean, I don't know if it's representative of a national sample, but we also see, like when we're looking at prevalence, we also see that this study actually showed that bisexual women were the highest prevalence with migraine, with at 37% versus lesbians, which were at 25%, and then bisexual men following 23%, heterosexual women at 20%, and gay men at 15% and heterosexual men at 10%. Well, when we look at the overall prevalence, I think if you kind of mix those up, the prevalence will be very, very high. So I think this was within their study population, but it does beg the question to understanding, how that plays a role as well in prevalence. And even before we even look at disparities, because disparities are preventable differences. Like when we look at disparities, and there are preventable differences in whether it's outcomes or disease severity or that sort of thing. Really, just understanding, the prevalence of the actual disease, and kind of if I may, I want to share a story, a very quick story. This happened about maybe 2-3 years about 2-3 years ago, and I was seeing a patient, with a trainee, an upper level trainee, and this patient had they had severe head pain. It was throbbing. It was associated with nausea, vomiting. It was debilitating. It was, I don't know if it made it quite chronic, but it was, I would say at least 8 to 14 days a month. And I asked the trainee, I said, what's the diagnosis? And the trainee said that, well, the patient is a man, so it can't be migraine. The patient is a man, so it can't be migraine, so I'm going to go with tension type headache. Well, see, unfortunately, the trainee was not correct. And that gets to another point that that men get the disease as well. In fact, when we look at some of the disparities in diagnoses, there may be, there's gender biases in which it's actually maybe on the opposite way, where women are far more likely to be diagnosed than men, suggesting that there's a gender bias in the diagnoses, and that may be a very important barrier for a man. And then, along this, and we were talking about disparities. When we look at Latino or Latinx populations, there's studies suggest that they're 50% less likely to receive a diagnosis. There's also studies that look at, so there's mixed results when it comes to African Americans or people of color. And there was a study that was done probably about almost 20 years ago now. It's hard to believe we're in 2026, right? So this was done it was published in 2008, that said that African Americans were less likely to get a diagnosis. However, a more recent study looked and I'll explain this. So it did not find it race-based. By the way, and this is my opinion. So I always like to tell people, I said what my opinion is versus, okay, this is what the data shows, this is what my opinion is. But data will support this. I actually believe we're all part of the same race, the human race. That's just me. I think we're all part of the human race. That's just me. I do feel that race is a social construct in which there's been discrimination. So instead of there being separate race, there is racism. Okay, not a lot of. I know people that don't agree with me with that, and that's okay. I'm okay with that. But there's a lot of evidence that would suggest that we're all part of the human race. I just want to say that. But when we live in a race conscious society like the U.S., whereas race conscious, there are race-based disparities or racializations that occur. And so back to that study that I said there's mixed results. This study showed that there was, we like to use the word, but there was a trend toward disparities in diagnosis of people of color, African Americans in particular, but based on race. And when I say trend, some of the hardcore statistical people will say it's not a trend, right? But when we when we look at when we do a lot of our studies, to make clinical, not clinical, but statistically significant, a lot of times it's usually set that it has to be less than 5% due to chance. Okay, and so this study that I'm speaking of was 6%. So it didn't make that
You should probably tell us the name of the study, so if anyone wants to look that up.
Oh, what was the study? That was a study
Was
with
it Overcome
I
or?
think it wasn't Overcome. It was before Overcome.
Okay,
That
we'll
was
put
the
it in
study.
the
Yeah,
chat.
I'll put it in the chat. I'll put it in the
Okay.
chat. So, but there was, I mean, it was the value that we call it the p-value. So it was a 6% chance that this was due to, I mean, that it was just due to chance. And so that's why we say it wasn't statistically significant. However, it did not gauge the clinical significance of that. Right, so there's a 96% chance, a 94%, I'm sorry, 94% that the results were correct. But again, when we look at a really scientific a way or statistical methods, we say it's not statistically significant because it did not reach that less than 5% chance. So I just wanted to bring that out, that we see that racialization, right, or when people are racialized, right? I mean, because people we all come from different backgrounds, ethnicities, and things like that. That there is a suggestion, at the very least, that there is really with people of color that there is definitely underdiagnosis. And I want to one step back, and then I'll stop. One step back. Migraine is underdiagnosed in general, but we see that there's a extra. So there's we call it extra. They get a little bit extra misdiagnosis or underdiagnosis when it comes to some of the populations that have been marginalized or historically marginalized in the past. So I just wanted to say that. And
So you already just answered my question for you, which was about the role of gender and race, or even the stereotypes in migraine diagnosis. And you mentioned men may sometimes get underdiagnosed because they're men, but I would say women may get underdiagnosed in a different way. Sometimes they get labeled as a psychiatric disorder, tension type headache, because they're a woman and they're hysterical, right? So I think these things play up in a different way. And you also answered nicely about the racial differences. What are some tools that clinicians can take to really get that correct diagnosis? I know that you've been involved in talking about ID migraine.
Yeah, ID migraine, and I love it. And I believe the very first person that I heard that I know is very familiar to American Migraine Foundation is Dr. David Dodick, and I think I heard him in a lecture say you want to pin the diagnosis, right? You want to pin the diagnosis, which essentially is ID migraine. So pin photophobia. I is intense. So is it intense enough where you are disabled, or the severity is very impairment, right? And then N is nausea. And so at least two out of those three, which is basically ID migraine, at least two of those three are suggestive, right? With headaches are very suggestive, a positive predictive value, very suggestive that you have migraine, right? Or someone is living with migraine disease. And so again, obviously migraine is a diagnosis with exclusion, so we want to make sure other things are not happening. But that's a quick screen that's actually been validated in different countries, in different languages, and that it can be done in different clinical settings, whether ambulatory settings, whether it's primary care, there's neurologic settings. I mean, it can be done. It's just a quick screen. It's a 3-question. And I'm all about having people empower themselves. That's why I really love the American Migraine Foundation, because now you who are watching this, or if you have friends, whatever, it's like, oh, there's a quick 3-question screen that can be asked, and then you can come in and say, hey, I'm screening positive for this, or And
So
so
if
that you're empowered.
you
Yeah.
answer two out of the
At
three
least
is
two out of the three.
positive, photophobia, impairment,
Hmm.
right?
Yeah,
And
and
nausea. If you get
nausea.
at least two out of the three, then your likelihood of having migraine is extremely high.
Right. Right. Yeah.
Great.
And so yeah, yeah.
Yeah,
Excellent.
and there's been research where when patients come in and say I have migraine, they're almost always right. So it's very important, I think, as a clinician. I mean, it's very significant when a patient comes in and tell me I have migraine. It's almost always 100% right. So I think you feel empowered to tell the doctor, I think I have migraine specifically, because that will force them to review criteria and see if you meet them.
I,
Great.
I,
So Dr. O'Brien, we're setting you up quite nicely, right, in terms of understanding the disparities, issues with access, right? And so as mentioned that if you have migraine, then in some ways you have issues with access because getting the diagnosis is delayed, getting the right treatments is delayed. Can you tell us a little bit about the insurance barriers that affect people with migraine in general? And then are there issues across populations in terms of access for treatment?
Absolutely. Well, you know that insurance barriers can significantly impact people with migraine and often more so than those with other chronic conditions. It reminds me of a patient who I saw about a year ago when one of these newer acute agents came out, and this patient came into my office and had a migraine that was lasting longer than 3 days, had tried their over-the-counter medications, had tried their prescription medications, even the newer agents, and it just wasn't cutting it. So I wanted them to try a new medicine that came on the market and had to get prior authorization for that. And typically, with prior authorization, it requires patient and providers to get approval before a certain medication or treatment can be given. So I'd requested an urgent approval for this patient and was told by their insurance company that it would take, 48 to 72 hours to get the answer. Well, in the meantime, the patient continued to deteriorate and eventually ended up in the emergency room. This was on a Friday, and they ended up staying in the hospital for 3 days to get treatment that we could have given at home. But that patient stayed in the hospital for 3 days and ended up missing their young child's rehearsal. So, in terms of prior authorization, I feel like that's like, a dirty word to a lot of us providers because we do spend a lot of time trying to get the treatment and care that our patients need. For patients with migraine, delaying care is unacceptable. Um, Prior authorizations also increase administrative burden and results in interruptions really in effective therapy. And if patients aren't getting the right treatments, what happens is that can also worsen the disease, and patients are at further risk to becoming chronic.
And what was
Now,
mentioned earlier is that if you're underinsured, that's maybe even more challenging, or if you're not aware of navigating the kind of health systems, right? Things may be
oh,
more challenging.
Oh yeah, absolutely. And even for those who are underinsured, when you think about cost sharing, so patients who may have to pay out of pocket, or even individuals who have high copays, um, typically with these migraine medications, it still makes access to these treatments unaffordable, even when they're clinically indicated. And people with lower incomes especially are affected, and it leads to, further disparities in access and adherence.
What about rural versus urban, like kind of even getting to a headache specialist?
You're exactly right. And I just recently read that in terms of rural communities, I mean, in terms of access to primary care, it's really low. And we think about government mandates and trying to increase access, physician access for patients. That access still is higher in urban communities than there are in rural communities. So typically, patients are then accessing primary care issues in the emergency room, where again, these costs are significantly higher. So this is not an issue that affects patients with migraine and families, but it really affects, our economy.
Yeah. Dr. Bagontas, you've done some work, I think you mentioned in Hispanic communities, and I know that where you work, there's some large populations. So how does language barrier play into migraine diagnosis, treatment adherence, and outcomes?
Um, I mean, I think a few different ways. Firstly, a lot of our headache centers are not designed for people who are non-English speakers. Like you call, you pick up the phone, someone's going to be speaking English. So even just that kind of initial getting the appointment. Um, the second thing is not only the language, but kind of the cultural aspect. How are you received? Like when you show up to your appointment, does someone roll their eyes and say, I have to call the interpreter? Or is it a welcoming environment where, they're warm, maybe say a few words that they know in your language or not? Um, and then it's practical things, right? And some things that we don't even know as providers. So when I prescribe a new medications, will the instructions be in that patient's language? How are they going to be able to know how to use it? And who will help them? Again, just like Dr. O'Brien mentioned, dealing with insurance companies, a lot of times people who don't speak English. May have been in the United States for a certain number of years, may or may not be familiar with things like prior authorizations. And they come back to the clinic and they say, doctor, you didn't refill this medicine for me. Why didn't you do that? Right. And so it's like, now I have to explain what the prior authorization is and, and how it only lasts this long and how the formulary change. Oh, January is my worst month, I think probably for all of us, because the formularies are changing and the medications are getting denied and we're having to think about appealing to the insurance company. So I think for non-English speaking patients, all those barriers just are higher.
Thank you for that. Carrie, hold on there because I'm going to come back to you, which is us, American Migraine Foundation, to really focus on some of these solutions and how we can get involved after we've had this discussion. So continue to take your notes.
I sure
I see you taking your notes.
see it.
Dr. Charleston, let's talk a little bit about social determinants of health. I think that not everyone is aware of what they really are and how they impact migraine care.
Yeah, so excuse me, social determinants of health. There's a saying that I have actually when I talk, and people usually don't come in and say they have a social determinant of health deficiency, right? They usually say that they're hungry or they don't have a ride or maybe they're late or maybe they don't. I had a patient that called me and said, "Baby," I mean, she was an older older African American lady. She was like, "Baby." Well, I just can't get a ride. I can't get transportation. She was trying to come for a procedure visit, and I'm glad that we called her to kind of see what's going on. They'll say that they may say that they're lonely, or they may just not say anything at all. So when we look at social determinants of health, we're really talking about different social and economic factors that drive health outcomes, and this can be, I mean, anything. I mean, there's a certain definition that the Centers for Disease Control has said. The Kaiser Foundation has some things, but essentially it's how the neighborhood or physical environment or education or food or the community or social context or the healthcare system, economic stability really plays a role. Like how people live and how they worship and what's their culture. And these things do play a role, and they, in fact, drive health outcomes. Like, for instance, if we look at economic stability, we were just talking about insurances, right, and everything. So employment, income, or expenses, or debt, or medical bills, or just having support. Another thing, if we're looking at education, right? Headache literacy. There was a paper written by some dude that talked about such thing as headache literacy, where we're really looking at health literacy when it's related to headache disease. So it's two different factors, right? So there's the personal resources and not just the knowledge, but also the personal resources in which to help. And I always, again, I like to use the word empower the medical change, or understand the medical change, or how do we work through these. So there are different again, social determinants of health. So obviously we're looking at things that may be under, it's kind of like you see the health, but you don't see these things that are underneath that really helps to drive income, public safety, right? I mean, things that really helps to drive, or determinants of that health, right? It's
So
like an
public
iceberg. We see the top.
safety,
I
your
mean,
environment, food,
yeah,
housing instability. I mean, that is really huge for a lot of people, right?
absolutely.
And so what I think we have a mixed audience. We have patients and we have clinicians, we have caregivers. So what can clinicians and patients do to start that conversation and try and tackle some of the social determinants of health?
Well, I know there are. I mean, some people, some clinicians are starting to put in different screening tools, and I think, and I've seen some of the things in the chat where people have been written off, and everything. It is hard. I mean, it is a tough situation. And I think that it's not easier said than done, but the American Migraine Foundation actually has a good resource to find headache specialists, people that are going to take your disease seriously. I think that that's a good step. But there's also screening and being able to really speak up for yourself. There is someone that talked about, and there are what I say, implicit biases. So there are implicit biases, and I know we kind of getting a little bit off of social determinants of health, but there are implicit biases that not only do patients have to overcome. I mean, us as clinicians, we have to, especially if we're in the minoritized. I don't think we're a minority, so please don't think of yourself as a minority. Okay, people have been minoritized. There's a difference, right? And so anyway, that's another thing of mine, but that we overcome. And so finding out, or doing the best, because again, there's no magic wand answer, but having providers that do care, finding providers that do listen, doing, I always say, people doing their homework. Again, there's a fantastic resource. I think I would say at least over 90% of the patients I see, or second opinions, or what have you, I am referring them actually to the American Migraine Foundation. Why? Because you can search whatever you're doing. Now, they don't have everything. It's not perfect, right? But there's things, there's a great search engine where you can, again, find out things about your disorder, find out, like, you can even find, like I said, you can find practitioners, but find out things about the disorders so that you're equipped too. And again, if people are not listening, I mean, there's a way, there's a communication, I mean, you used to call it bedside manner, but I do think it goes both ways, but finding someone that cares, and again, it may not, I mean, it's not that many headache specialists, but there are headache specialists that care. I mean, there are plenty of headache specialists that care. Being very authentic, I think being very authentic, from a patient side. Now, I try to be authentic from a provider side, because authenticity usually breeds authenticity. So if I'm authentic and I'm trying to get this social concordance, for the practitioners, you really wanted to try to find social concordance, because you're not going to do the same, or you're not going to be the same as everybody, and that's what makes everything so special, right? The diversity that we have, right? But learning, and maybe maybe you have kids, maybe you don't have kids, maybe what is that you can connect. Right, trying to connect, and I know that time is limited in visits and things like that, but trying to connect, I think, on a somewhere on a personal level. Don't have to be super deep, but somewhere on a personal level, right? That, oh, your kid's in school. Oh, my daughter's playing the violin. Yeah, my wife has her ears plugged up. Whatever the case is, right?
Yeah.
As she's learning, that's whatever.
So I
So
think you're getting into our next point, which is really about, there's all these barriers. It's not easily these disparities, but how can we better connect with one another when sometimes we have very different experiences, life experiences, backgrounds? How can we improve communication, reduce mistrust, and help patients feel validated? Maybe Dr. O'Brien, you want to start with this one in terms
Yeah.
of building trust and rapport?
Absolutely. I think, with medical mistrust stemming from these historical injustices, discrimination, negative experience, healthcare, can significantly impact migraine care in marginalized communities. So, providers can take
Or
several
even just
actions.
even just having migraine and feeling vulnerable,
Yeah.
right?
So it's important for providers to validate patients' experience. So listening actively, giving patients uninterrupted time to describe their symptoms and concern, using empathetic language that acknowledges the real impact of migraine on a person's daily life. You can say things like, I understand your pain is real and disruptive. You want to avoid dismissing the patient and refrain from minimizing or questioning the legitimacy of their pain, even when physical findings are lacking. And I also often ask open-ended questions. I think as physicians, we may be a little concerned about that because our time is so limited. But I will tell you that if you do that, most patients actually end up answering a question in less than a minute. So encourage patients to share details about their experience and also demonstrate cultural humility. Be aware that there may be cultural differences in expressing pain and also seeking care. And most importantly, I feel like for me, is involve the patient in the decision-making process. Make sure that you are able to collaborate on the treatment plans and also respect the patient's preferences.
Great. So I think I want to also focus on solutions, and I also want to have a little time for Carrie to talk about from the AMF perspective what we want to do and how we want to partner with patients and clinicians to really move the needle. But first, why don't you guys just kind of give me a free thinking idea to how you think that we can tackle this problem to reduce disparities, the impact of social determinants of health, mistrust, and all that we're dealing with.
So I'll just say, it's important to increase provider and patient education. I think unfortunately, even though you may go to a neurologist, I will tell you there are many neurologists who are just not comfortable or may not know how to properly diagnose and manage migraine. And then streamline the access. How do we simplify insurance processes and reduce these administrative burdens and hurdles in care? And then, continuity of care is important to me. I actually opened up a practice where I can have that time with the patient so that, when they come in, they are seeing me and always seeing me and not seeing somebody else who may have a different plan for them. Maybe thinking about expanding telemedicine. And we talked about the lack of access in certain communities, or there are states that don't even have headache specialists. So I've taken advantage of the IT. I think we talked about IT and virtual visits and how do we increase that access in underrepresented or underserved population. And then developing patient resources. There were a lot of questions in the chat, and I think AMF has, is a wonderful place to start in terms of getting educational materials and navigating support. And then finally, feedback. I love getting feedback, and so encourage that feedback and ask regular questions, not just for patients, but also
Mhm.
providers. Ask those questions and get input so that we can improve services and resources.
Dr. Vogontas?
Yeah, just to follow up on that, I agree with everything Dr. O'Brien said. The United States is a very large country. There can be unique challenges depending on where you are, rural, urban, the type of communities you treat. And so sometimes looking at kind of local structural solutions, can be a little bit different. I'm going to give an example. So I work within an internal medicine practice, and when I got there, I realized, some of the patients would be candidates for Botox, but the clinic had never had anyone who had given Botox before. So what we did is we started off with the first patient, and we went for the prior authorization, and then we had to figure out how to get the Botox to the clinic. So long story short, that kind of starting off with one patient and starting that process off kind of opened the road to the following patients. The clinic staff got educated on what I needed for the procedure, and the people doing the support staff who did the prior authorizations got more familiar with that process. So and like Dr. O'Brien mentioned, in some rural areas where transportation is going to be a huge barrier, utilization of virtual visits and figuring out how to optimize those, especially in patients who might not have stable internet or might not, or older, don't feel comfortable with that technology, or who might need an interpreter. So, in some ways, for those of us who do this work and who want to find the solutions, when we focus on patients who face the most barriers, and those barriers can be multiple in the same person. When we try to find the patient who's going to face the most barriers to accessing the best migraine care and structuring the system so that that patient can receive that care, that's going to help everybody else, because you're going to create a system that is going to make it easier for everybody to get the best care.
Dr. Charleston?
Yeah, I agree, and I wanted to kind of change gears just a little bit for those who have experienced racism and trauma as racism. Okay, because and it's been said different things have said where healing can come from counseling, spirituality, seeking justice, and social support, and racial socialization messages that emphasize cultural pride have also been found to moderate the relationship between racism and post-trauma reaction. So one of the things that really stands out that I've seen is really working to receive treatments in a safe space, where several studies have suggested that people of color receive discrimination in healthcare settings, which we've probably seen in the chat. And a lot of that, and we don't have a lot of time to go into a lot of the biases and implicit biases and that sort of thing. But finding that safe space, taking care of yourself as well. So making lifestyle changes, beginning with exercise routines and meditations, where you need help from support and family members and the community, and help from people or support from people who have also experienced similar situations. Trauma-informed psychotherapy to help a person identify their emotions and process their experiences and identify healthy coping tools. And if medications are needed, if there's other things that occur with the trauma, the medications are needed, then, to whether help with sleep or any depression or anything that results from these racialized trauma, that's really important as well. And so those are just some coping tools, and even going on a limited media diet to avoid images of whether it's racial abuse or mistreatments, and then there's actually, because someone had mentioned microaggressions, I actually did a point on a presentation on microaggressions and everything, and identifying it, but identifying role playing, right? Using people, like if you have a community, role playing, like how do we respond, or what should a bystander do? Like if you see this, what should a bystander do? I mean, it's hard if you're one-on-one in a meeting with a provider or what have you, but just kind of role playing and just knowing how and when to respond. And so I think that is really important as well, with dealing with some of these things that can come from racialization and discrimination of people. Um,
Thank you for that. And we know that you published some nice work on the impact of discrimination, perceived discrimination, and migraine. So thank you also for that work. Carrie, you're up. I told you I was going to warn you. Solve all the world's problems now.
Perfect. We
Five
have
minutes.
9 minutes. We got it. Well, I wanted to say from some of the things you all are talking about tonight, those who are on the call who are patients, because I know we have a mixed group on the call. I don't want it to get lost that we are talking about a lot of things that are going to have to take place nationally, internationally, that are not a quick fix. And I think I want patients to take away from this that there are providers like those on this call who do see you, they do hear you, they do know these are issues. You can hear because they're speaking things that you're going, yes, yes, we know these problems. What do we do? And as an advocacy organization, first, I want you to find a healthcare provider that hears you. And one of the things we really have talked about this year and going into last year is okay is not enough. And so if you are seeing a provider that says, "Oh, how are those? How's the head pain going?" and you're like, "Oh, it's fine. You know, it's a couple of times a month, or it's I only miss like 5 days of work, you know, now." And they're like, "Oh, that's great, because I know you were at 15." That's not okay for you to be just let that be okay. Like you come up with what's okay for you. And we just want to encourage people to part of advocacy is having that partner with you at doctor's office visits or having someone there who's like, no, no, no. He or she has these still 5 or 10 days a month or whatever it is. Advocating for yourself, you may think, oh, I'm seeing this headache doctor and they said 8 or 9 are okay. But like Dr. O'Brien said, there's still a lot of neurologists that will say they'll say migraines, and we always immediately are like, wait, they're not probably as versed in the specialty yet. And so it's okay even if you push back a little bit and say, I'm just not okay with that many still. One of the things I have a huge laundry list as you guys were talking of like, oh, let's bring this up. But I want to encourage patients to, if there's something that resonates that you're hearing the clinicians talk about tonight that you're passionate about, your voice is important. Someone mentioned microaggressions. Dr. Charleston mentioned that if you feel like that's something that you're like, what do I do about this? We're part of a larger group of advocacy groups, and there's one that works in policy, and there's one that works, more in education, like us, and there's some that there are groups that could help you formulate how you can get involved in advocacy as small on a small scale or a large scale. And so I just want to encourage people, if you're not sure and you've got that passion, email us and we'll help connect you to the right group because it takes all of us and our voices to be heard. One of my colleagues that's off camera right now was at Headache on the Hill last week, and I think Dr. Charles, you were somebody else may have been on that. Dr. Monteith, you may have been there as well. And that was advocating with our legislators to say, hey, we've got to have changes in step therapy. So as patients, you all have so much you're dealing with, and some of you who have 15 or more head pain days a month, you probably don't have the energy, but maybe your loved one watching this does, and they go, this isn't okay for our family. I want them to get the help they need. So I first just come with a passion with you, and that we want you to be able to let your voice be heard. Secondly, from the patient perspective, I want you to hear that there are clinicians like those on this call are out there. Don't feel like you are stuck with the clinician you have. I hate to say this. I am from rural South Carolina. I don't hate to say that part, but I hate to say that we sometimes get stuck with the doctor I always saw, and well, they still say I can take this medication. It was around the
Right.
90s. I'm asleep every night by like 8, and I miss most of my kids' ball games, but it's only like so many days. If you are watching this and you have a loved one facing that, please, please, please know that there are better alternatives now, and there are some great options, and people are, I mean, the research that's out there right now, the daily amount of white papers I get that are, this is coming out and this is coming out, we're trying this. There are better alternatives, and sometimes it takes a while. It's like psychotropic medications, it takes a while to find the right thing, but I want you to find the right doctor. So first, that's my push. And then also some of the resources we have patient guides on our website. Dr. Charleston talked about some of the resources we have. We'll put in the chat the patient guides. They're a great thing to take to your doctor if they seem dismissive and you love everything about your doctor, but you want them to understand what it is to have a migraine diagnosis. We also are having those translated in Spanish, which that's in a partnership with the American Headache Society. So those will be available soon as well. But if there's a really big resource you see missing, let us know. Send that to us at info@americanmigrainefoundation.org. Our website's our email address is on the bottom of our webpage. I want to know what printable you would love to take to your doctor. And we're starting a long list, and then we're going to prioritize and say, let's come up with 5 this year that you all are telling us you need to have in front of your doctor. So your voice is so, so, so important to what we're doing, and to the other migraine groups as well. I could keep going, Dr. Monteith, but that's my highlights that I
No,
definitely wanted to make sure.
I think what you mentioned was great, and that we do have a lot of these resources. Maybe on this topic, we may need to create something specifically, a patient resource guide, and kind of tap into our experts here. There were some comments in the chat about microaggression. I think that was answered. And then multiple people in different ways have mentioned frustration with accessing treatment or getting the validation they need from their neurologist or other provider. And so I think, it goes back to that communication and to, first of all, being knowledgeable yourself that there can be better, right? There can be higher standards of care, and recognize there's no ceiling to that. And then doing your best to be a part of that conversation in a very frank way. Neurologists, headache specialists tend to be very frank, and I think they appreciate even you being very forthcoming that I really want to invest in this relationship, and I need to partner with you for X, Y, and Z. I think most headache specialists that I know of will feel very kind of open and happy, and not, why didn't this patient show up? Right? And if those tactics haven't worked, then recognize we do have the Find Your Headache Specialist link on the American Migraine Foundation, and we're always here for you.
Dr. Monteith, can I mention 2 more quick things?
Ken, you're the CEO.
Oh, perfect. Great. Okay. One is Black Men Have Migraine Too, the resource. There's a fantastic group of men who have started this group. One in particular who started it, but he is really putting out the message that Black men have migraine too. And he's gotten me really excited about it because, and I'd love to, Dr. Charleston, we could do a whole segment on this from a Black male perspective. But he got me really passionate about the fact that men in general in pain and going to the ER is a whole other ballgame. And really, Black men speaking up and saying, this is a debilitating pain. I didn't realize this is what was happening to me. So if you all are interested, or if you have a spouse or know a loved one that could have migraine, that's a great resource. And again, they mainly have a Instagram page. I think there could be a website as well. Great resource to check out. And I forgot what my other one was because I got so excited about that one. I'll think of it.
I was going to say kids have migraine too.
Yes, yes,
Children do, and yeah.
yes, yes, absolutely. But I encourage you all to let us know what you aren't finding out there for resources. I just thought of the other thing I wanted to share. Make sure before you go to your annual visit, if you're not going to your neurologist and you're going to a GP, I'm just going to put this out there. Make sure you put that priority of, yeah, you may have AFib, someone said in the chat. You also may have debilitating migraine. AFib is huge. I get it. My mom suffers from that. But make sure you don't say, oh, yeah, and migraine. That's one of the reasons it gets kind of glossed over, is because the cues from you in a 10-minute meeting with your internal medicine doctor is going to be what drives what they help you with. And so again, if you can take someone with you to those appointments and say, don't let me leave without these 3 things talked about, it's so important. So as an advocate for you, I just want to encourage you, don't hesitate to speak up. You're not bothering them. That's what they're there for. Find a different doctor if they're not listening. Dr. O'Brien said it beautifully, that their empathy is important, and more doctors are having these practices where they have longer meetings with you because of that. So But thank you, Dr. Monty. Thank you for hosting this tonight and for this important conversation. Please wrap us up because I'll just keep talking.
Yes, yes. So I mean, I would like to thank the team, all of us. I mean, we put so much work into really trying to get the right questions, the right conversation, and there's really just so much to go. And if you have migraine, you're a warrior. Doesn't matter what you look like, what your package like. Support one another, love one another, and really empathy is really an important thing. But also let's just make sure that we're being supportive and communicating our needs. And that goes both ways in trying to improve this migraine journey. Any last thoughts to our panel before we wrap up? We're 1 minute over. And to our folks in the chat, we will get back to you with maybe some brief responses to your questions. Any last minutes?
No, I just again, I want people to leave with hope. I want them to leave empowered. I want them to leave inspired, by this conversation. And we just touched the surface of different things. We didn't have we had an hour, so we didn't have a lot of time. And so I just do want everyone to leave with a sense of hope. And I just really thank you again for allowing me the opportunity to share. And I know I owe a resource. I got to find it and I'll send it. So we'll figure out how to get
We have
that
a couple of
into you.
resources because there's someone who's also
So,
interested in your discrimination paper. So we'll wrap some of this up. I promise we won't leave you hanging.
Yeah.
Dr. O'Brien.
Thank you again for the opportunity to be a part of this. This is important. And again, we're all in this together.
Dr. Vagones.
Yeah, thank you so much. I think, we've acknowledged some systemic challenges, some structural challenges, and that we all face. Patients, providers, a lot of your providers are patients too. And I think the teamwork and the solidarity in facing those is really important. So I hope you can find that with your primary care doctor, with your neurologist, and keep going.
Great. Well, thank you all for logging on, and we will have this up on YouTube, hopefully pretty shortly. Thank you so much for listening and being part of the conversation.
Yeah. Thanks, everybody.